And I think always treat the patient, not the test, right?
I was wondering, I helped some dental students, medical students, go out and they started a mobile unit for a dental service, especially in the rural areas where dental, service is almost non-existent. And, but it was very interesting to me when they're explaining to and giving their presentation to the audience, telling them the connection of dental hygiene, the gums, the teeth, the mouth, and the heart, and how that's connected. Do you have other connections like that that we can use, we the community advocates, that we can, so that we can include in our preventive,
Yeah, that's a great point. And when the recommendations for antibiotic prophylaxis, dental prophylaxis changed, remember how we used to give antibiotics to everybody with mitral valve prolapse and all of these conditions that we don't do anymore? Those recommendations were joint guidelines from the American Dental Association and the American Heart Association. And they recognized the link between oral health and vascular health, and the inflammation is a big part of that. So one of the ways to think about it is to have good vascular health, you have to have good oral health. And so instead of giving antibiotics, the focus was clean the mouth, clean the gums, keep your mouth and your gums clean. And that's better than using antibiotics. So the prophylaxis guidelines changed dramatically. This was a long time ago now, I think 2005. Changed dramatically several years ago. But it's a very important thing to educate people about, that oral health and vascular health are connected.
Amparo, about half of my female patients are over 75 years of age. And we have less research in that group. Do you just roll the pre-75 guidelines onto that group if they tolerate the therapy and go with that at the current time?
Yeah, I do, because usually they're secondary prevention patients at that point that we're seeing in our practice, cardiology practice. So I just tell them, though, that we don't have evidence to say that I should be treating them with these drugs at their age, but we also don't have no evidence that says we shouldn't. And so I just tell them I'm going to extrapolate the current guidelines until we get data in the patient population that's older and growing and female. And this is the same for men as well, older men. Because I don't know what else to do with those patients. I know that they're at high risk. I know that they're at the highest risk for recurrent events. And we have no data that says we shouldn't be treating them and we should stop. And in fact, something interesting just came out on secondary prevention and the use of PCSK9 inhibitors, which are used to treat heritable hyperlipidemias or those that are not responding to statins. And there's mortality reduction now by taking LDLs to 150. That was just shown in secondary prevention. And I think we're just getting more and more data regarding aggressive management of risk, vascular risk, but also the components of vascular risk like LDL. So I don't see the data going the other direction. So that's, I don't know, I'm interested in what other people here who take care of patients do. Same thing.
Second question is, when we started the Coronary Drug Project years ago, decades ago, we looked at our patients who were mostly male, and we assumed that there was some kind of protection premenopausal of that situation, and our best guess at the time, 40, 50 years ago, was estrogen. And estrogen turned out to be a total failure at that point for increasing survival, although there were some improvements in vascular function. but we could not really ascribe a benefit at that time to it. And so women have a lower premenopausal event rate and then a higher, or it catches up, postmenopause. In all of your research, is there something we can encapsulate and put into a pill for the premenopausal condition that we could then offer to postmenopausal women and to men at the same time as a, quote, cardioprotective pill?
I would make a Life Simple 7 pill. I think that's by far the best. I mean, lifestyle therapy is called therapy because it works. It's very, very effective. And, you know, what we're talking about is primarily a preventable disease. So Joanne Mason at Harvard has done this wonderful statistical modeling showing that 80 to 90% of heart disease is preventable. I don't know that we have any other disease that's that preventable. But as I said at the beginning, I think we have this disconnect between a population at risk that thinks that they're immune. Your point about premenopausal women being protected is relatively protected. That's one word that needs to go in there. And then also it depends on age, because you can tease out the effect of menopause from the effect of age. And in most women, they do go together as women age. They're likely to be menopausal, of course, but not always. And menopause itself, menopausal status itself, can up to double the risk. And that can be even greater once a woman attains older age. But the prevalence of cardiovascular disease doesn't match between men and women until age greater than 75. So still prevalence is lower, but death rates are higher. And I think some of what I showed you about underutilization of evidence-based guidelines, the physician and provider discomfort, lack of awareness from our patients and our communities. And all of these factors, I think, go into the higher death rates with the lower prevalence, because that's the other paradox.
Other questions? So if you look at our research studies over the years, there is a undersampling of women in a lot of the NIH trials, and it's probably 20% to 30% fewer women than are represented there. Is there a continued bias against women in our NIH funding and grant and selection recruitment for that? Or is it the fact that there's also an age limit on many of these trials, and many of the women who have cardiovascular disease who would be, quote, qualified for it are already over 70 or 75, which is the upper limit of these trials, so they get really selected out because of their advanced age at that time?
Yeah, I mean, some of those factors, so we know that there's under-participation of women in clinical research studies, but we need that participation to fill in some of the gaps that I mentioned and to get the data that we need to really have good evidence in areas where we still don't. For example, in management of SCAD and in coronary, non-obstructive coronary disease, such an important disease. And so we have under participation of women in clinical trials for a number of reasons. And then we have more comorbidities at older ages. We have other factors, societal factors, such as childcare. So if you go and take care of yourself and participate in a study, who takes care of your kids, right? And is the study site family friendly? Can you bring your children? Is there childcare there? There are all of these other factors that really go into increasing the participation of women in clinical studies that have to really start to come into play in order to have more women involved. So right now, one way to get around this problem is to oversample women. And some studies are doing that and reporting their data that way, over-enrolling women. But it's a huge problem, and one where I think we all have a role to play in encouraging women to participate in trials and trying to bring up some of these barriers, making sure that their voice is heard and becomes to them.
Any other questions? Yes.
I will always have questions at the tip of my tongue. So, our big overarching goal here, and in all of our right care communities, is to drive the rate of preventable heart attacks and strokes as close to zero as possible. So, two parts to the question. One, can you share that Harvard study with us? I'll post it and distribute it. And two, for the capital region, what would be your big asks of the health systems that are present here to drive down the higher rate of acute MIs here in the capital region?
Okay, the first one's easy, yes, I'll share that. The second one is harder. I think we need to just work together. We need to have, kind of a joint commitment saying this is a major health problem in our region, and we're Inland Valley, so we're not in the coast, we're not in the lower death rate area of California, and the community that we serve in Northern California is a high-risk community. I think we need to have a collective will and alarm, if you will. This is an important health issue that if we work together, we can make a difference in. What can we do? Well, do we see billboards saying heart disease is a leading killer of women? No. Do we see anything about heart disease is largely preventable? No. Do we have public health advertising on, healthy lifestyles? No. I remember a really, really effective campaign when cigars were popular, like in the 90s. You might remember this, Jessica. And young men were smoking cigars as a trendy thing. And so there were several billboards on the Sacramento freeway showing a very suave young guy, with his whiskey and a cigar. And next to him was the same guy with 17 cigarettes coming out of his mouth, because one cigar is, I think, 17 cigarettes. And it was extremely effective. I think we need those kind of counterpoint. And we can, I think, all come together and put our heads together and push for education. Because really, if you don't think that you're at risk, it's just so hard to really even take the first step at practicing prevention. But I think education, and we have shown that if you educate, it will translate into healthier behaviors, it will translate into improved clinical markers, and it will even translate into the lab measurable biomarkers, which I think is amazing, that you can do that with just educating people. And what we educated about was the symptoms, the risk factors, and healthy lifestyles. Those were the major things that we educated about. So I would love to see us collectively come up with ways that we can really do something that's impactful, or maybe some things that are impactful that will grab people's attention.
Well, thank you very much for what was a very comprehensive review of women's cardiovascular health over the years as it went through. And thank you very much for coming back to celebrate our 6th birthday, Dr. Villablanca. Thank you very much.